without a fusion, and none of us want a fusion. None of us want to have a big open surgery. So if someone can offer it, we find the things we want to believe that are out there. Yeah. So this, so the disclosure from my perspective is this is a new technique. It is relatively new. In our world, 7 years of clinical experience is still very new. It's not FDA approved as a use of these implants, so we're using implants from other things and applying them in this way. Now, obviously, the folks in that in our lobby out there are working on ways to change that. So device development and approval through the Food and Drug Administration will come. I'm confident. But tethering began just in 2011. So here is a patient who had that surgery done in 2011. Has had a lot of growth left. These are the general indications, but they'll vary based on who you ask by surgeon. But I think these are tend to be the patients that are best managed by tethering today, or at least have an option to be tethered today. But I would like to present you a little bit of, this is data that I presented to our surgeon colleagues, but it's important for all of you to see it as well. This is a comparison of anterior spinal growth tethering and posterior spinal fusion. And these are the Cobb angles, the size of the curve. At the time of surgery, we had 2 equal groups, both at 50 degrees. And you can see that those that had posterior spinal fusion surgery had a better correction at the bottom. Their curves averaged 10 degrees. And the tether patients at 4 years after surgery were under 30 degrees, under 35 degrees on average. That's not a bad spot to be. But it also is true that the air bar, those yellow lines on top of that thing, are huge. And the air bars on our little white line are small. It sort of speaks to the idea that posterior spinal fusion is reliable. It's reproducible. We get the result the same pretty much every time. But in tethering, we have some amazing results. We have some overcorrections that are just so phenomenal that the spine actually reverses and the tether has to be removed. And we've got some where it just doesn't work. And why and how we learn about all those things. This is a little bit more of the specifics of the data. So a lot more revision surgeries, a lot more, some that are converted to posterior spinal fusion after the fact. But again, you know, the posterior spinal fusion patients, 29% revision, what do I got here? Revision is 53% versus 0. Oh, I got it. Those that had a tether, 29% had a posterior spinal fusion. Those that had a posterior spinal fusion all had a posterior spinal fusion. So, you know, we can avoid fusion in some of this population, but it's at a much higher revision rate. So there's, obviously, depends how you read that. If you're a half full or half empty kind of person, you sort of look at that 2 different ways, and I think it's really important to kind of have that perspective. The causes of failure are many. You didn't have enough growth, you didn't do the right levels, some of it's our mistake by not knowing well enough what to do. The cord breakage over time is being found to be quite common. So 60% of cases, if you've got 4 years of data, have a tether that's failed. And they fail somewhere between 1.5 and 4 years. So there's a story to be told, and there's some spectacular success. But you got to figure out if you want to be the person making this learning curve, or coming, or taking a chance that you can avoid a fusion. And I kind of think, again, people sort of see that decision making very differently. It tends not to be a one and done for all the patients, but some of the early outcomes, again, are spectacular. Once you get a little beyond 2 years, 3 years, the results are a little bit more mixed. And the early results of many surgeries are spectacular, and the longer-term follow-up, unfortunately, is where we find whether it works or it doesn't work. And so being on the early front of this just puts you at a little bit more risk. But again, if you want to avoid a fusion, there's a shot at doing that. So I do think there's a future in which motion is coming for patients with scoliosis with large curves, as long as we can develop the implants to do it better. We need certainly more experience, both for the surgeons and in this whole decision making. A lot of research and development is still required, and we'll have to do more work with the FDA to get that through the process of approval. But I do think it's an exciting time, and I want everybody to sort of have this in the right perspective. I know I got some patients here who have had tethers and some who are considering it, and a lot of people who've had sort of the more standard approach of the spinal. Anyway, that's what we got for today.
9-hour surgeries to 3 to 5 hour surgeries, 6 to 7 days in the hospital to 3, lying flat for 8 hours to getting out of bed day 1 or post-op day 0 even at times. Significant strides in pain management with better non-narcotic tools in our arsenal. So kids are on narcotics now for after discharge anywhere from 1 to, we've got a few outliers, like 3 weeks. It's extraordinary to watch. Kids back then always wore a brace, now rare. Showers, 2 weeks, now day 3. Back to sports by 6 months. We have trouble holding these kids back. They feel pretty much like they've never had surgery 4 to 6 weeks after surgery. It's extraordinary. What hasn't changed over the years is that this is a big interruption in a family's life, and the time can be very challenging and stressful. And
I guess, the question was, what can you expect? And my answer to that is you can expect the journey. It's definitely a process. It's how you choose to go through the journey that kind of informs what the recovery looks like and what your after looks like. And oftentimes the physical recovery is somewhat automatic, as opposed to the emotional recovery is something that has to be very intentional. And those two things are just as important as the other. But the surgery will change you, but it'll be for the better. So we just wanted to share some thoughts on returning to normal. So what is normal? I think with scoliosis, that's always an interesting question. But after surgery, I think that I learned to call it a new normal. One of the things is getting back to things that you used to do, and getting back to soccer for me, because I was a soccer player, was one of the most important things for me. And it took a whole year, and it took a lot of courage and not getting frustrated and being patient. But I actually was better. I surprised myself. I was a better soccer player afterwards.
that time away from sports can often be more challenging for physically active kids than the time of surgery and that immediate post-op recovery. So we always encourage the kids to find some way to stay connected with their team as a junior coach or a manager, or even just going to the games and watching them. It's amazing what you can learn as a spectator. And you tell them, there's reasons that professional athletes watch tape.
And also that you'll discover new things that you never thought you could do. I really relate to the girl doing front handsprings and girls doing yoga, because I never thought I could do yoga. And I thought it was just for people that were flexible, not people like me. And what I found is, with a few spine from T2 to L2, that I am now doing yoga. Not only that, but I'm a certified yoga instructor with scoliosis, helping people with scoliosis to do yoga.
As you can see, you explore other interests, okay? You're not a one-dimensional person, so you're not just your sport. And the possibilities are endless.
Absolutely, and when I think of what the possibilities are, and I didn't think I'd be able to touch my toes again, or tie my own shoes, or to look at myself and not judge my body, or think other people in the room were thinking that, oh, that girl has scoliosis and what's wrong with her body, and to feel that judgment. But what I realized is that all of that kind of gets shed away through the emotional recovery, and that, like you said, infinite possibilities for what you can do with your life, and that you can love yourself with scoliosis.
The physical and emotional recovery happens at different rates. And parents and kids go through this differently. Parents and kids recover emotionally at very different rates. Often, like I said, the kids are back feeling just like themselves at 4 to 6 weeks post-op, and the parents are still sitting there saying, what just happened to us?
So I guess some of the most important things that we were thinking about the emotional recovery is being really open and honest with what you're feeling. asking for help and support when you need it, that there's no shame in that, and that there are lots of other parents and individuals and people that know this journey. And so it's really important to ask for that help when you need it. And it's okay for it to be hard and frustrating and often depressing at times, but that there's always the good outcome of it, and that you will come out the other side stronger and more resilient, and you're never ever alone. So we'll leave you with a couple survival tips. Amy and I really wanted to go through some things that we think will help during the recovery. One of the things that really helped me was creating a scrapbook. And I brought it up here, not that you're going to be able to really see what's in it, but it's something that has, you know, photos and different journalings and things that were part of my recovery, and being able to document the before, the during, and the after, and how far you've come.
You think differently about what is going on in the moment than you do a year, 5, 10, 15, 20 years later. Another thought was, especially, we always recommend preoperatively that you talk with other families. They're the ones who have lived it, know best how to get through it, and can be an amazing source of support and information.
And that allows you to be part of something that's bigger than you. I was actually part of the pharmacy research study, which I'm really proud of. And giving yourself a meaning for that journey, being able to be part of something bigger than you, whether it's the research or it's, you know, during my hospitalization stay, I allowed somebody that was about to go through the surgery to come into the hospital room and to see what it actually looked like. So whatever that looks like to you, I think giving back is very important.
Be kind to yourselves. Get a lot of rest if you can. Do what you can to take care of yourselves. Ask for the help that you need. Your medical team is here to help you and support you, and we want you to be successful at both the physical and emotional recovery. You can do this.
And you're never ever alone. You're definitely enough as you are, but you'll come out stronger and you come out more resilient. That's it.
Wonderful. Thank you both.
They're early. It may be at 18 years, you forget about it. And I don't know, could be something to talk about. So what do we recommend? There's a couple studies out there. This one's a little bit older, 2002. We touched on this a little bit in the surgeon panel. You know, our recommendations have changed over the last 10 years. So this was a survey of surgeons in the Scoliosis Research Society. So back in 2002, most people were recommending anything for the first 6 months, and then allowing some contact sports at a year. And then if you're involved in very high-level activities, almost never going back to it. So this study was repeated in 2015, and you can see things have changed dramatically. So people were allowing running at 3 months, non-contact and contact sports at 6 months, and then collision sports now at 12 months. And as part of that survey, Dr. Skaggs mentioned that he hasn't had a single patient. There was one patient in this group of 23 surgeons that had hurt himself in the post-op period, going back to skiing or snowboarding too early. So what do patients actually do? There's some interesting data about this too, and the good news is that they basically don't really follow our rules and get back to doing a lot more than they should, a lot earlier than they should, and they seem to do pretty well. So 93% of patients were back to non-contact sports by 4 months, and 96% by 8 months. So that should be a good indicator that patients are able to return to their activities. So activity after scoliosis surgery, this was a study from Dublin, Ireland, and some of the risk factors for delayed return to activity was starting out with a curve more than 70 degrees, having some postoperative weight loss, which I think is part of that deconditioning. You know, your muscles are getting weaker, you're losing weight, you lose your appetite. The narcotic medicines that we used to use in the past slowed that whole process down. And then some of the respiratory complications that could come up during that perioperative period. Also this study looking at how low you go in the spine. So, you know, the loss of flexibility can be determined by your last instrument and vertebra. So some of the questions that you should be talking about with your surgeon are there aims to keep the fusion to just the thoracic spine? What are the pros and cons of doing a selective versus non-selective fusion, like going down into the lumbar spine, in terms of how much I can do after surgery? So what does the future hold? There were some questions about what's my kid going to be like 20, 30 years down the road. So we have some midterm data, so 11 to 15 years after surgery. And basically what that data shows is that there might be some evidence of arthritis or degenerative disc disease, that's what that DED stands for, or facet joint disease, the joints that connect your spine, at that midterm, but there's no difference in function, no difference in pain, no difference in disability from people who haven't undergone surgery. So gender matched controls. So that's some reassuring midterm data. But again, like we talked about, there's no long-term data because we haven't been using these implants for that long. So basically there's many unanswered questions. You'll see that patients are getting back to everything they want to do for the most part, a lot sooner than it used to be in the past. And hopefully as we continue to improve, we can get you back to your sports faster. Thanks.
Great, thank you so much. We have a surgeon panel up real quick. We're going to what we know about long-term outcomes, including pregnancy and childbirth.
All right, final push. Congratulations on everybody for making it this far. A lot of this has been kind of danced around in other talks, and I'll try to condense it here. Although I've never had scoliosis and been pregnant, I've been pregnant multiple times treating scoliosis, and so I think that is why I was chosen to cover at least some of this topic. So I think, you know, when we're talking about outcomes, when we're talking about long-term, what is life going to look at, really I think we're getting to the heart of what being a parent is. And that is trying to shepherd your children from, you know, helpless babies to independent, functioning adults. And we want to make whatever decisions we can to make them the most successful and the safest in life. And so when we talk about outcomes, I think we're getting to the heart of what we really want for our kids. So make possible candidates for a parental wish list. I have 3 boys, 6 and under, so I think a lot about bubble wrap, so that as they jump off of things, maybe they don't break anything. If we can't do that, then maybe just a straight up bubble, both physical and emotional, especially in preteen, tween years. It'd be nice to have an emotional bubble protecting your children. Guardian angel, we would all like a real or pretend somebody watching over our kids and over us throughout life. And none of these are really possible, and I think even if we couldn't protect our children, at least having a crystal ball and being able to look into the future and see what their life is going to be, and knowing that information now, be proactive about setting them up for success with that crystal ball. So unfortunately none of those things exist. We don't have a crystal ball, but the next best thing we have is research. So what we try to do, what I like my job is, I like the idea of having a question, developing a study, answering that question, and then using that information to help people move the world forward. So sound research is great, but it's not perfect. So things to keep in mind as we talk about research and outcomes are that every person is an individual. So Dr. Newton stole my line about lies. I'm going to say it, damn lies and statistics. And that is to keep in mind things like, so if a study says that adult patients without scoliosis have back pain at a 4 out of 10 on average, and patients with scoliosis have back pain at a 5 out of 10 on average, that's a statistic that may be significant. But what that means is not every single person has a 4 with no scoliosis, and every single person with scoliosis has a 5. It means there are some people with no scoliosis who have terrible back pain, and some people with, or I should say without scoliosis, terrible back pain, and some patients with scoliosis who have no pain at all. So data is not a life sentence, but more just a guide to try to inform decisions, and again, try to do our best to clear up that crystal ball. Take it all with a grain of salt. That's also related to the statistics. We'll sometimes, you know, massage numbers or look at things in a different way, be able to make a conclusion, but don't just read the conclusion, don't just, you know, read what that person who is giving you the information wants you to know. Use your brain, dig into it, look a little bit deeper, and also think about things of what really is a difference. Like what we talk about, clinical, meaningful, significant difference. So the statistics may work out, but it may not translate into a really big difference for a particular person. And then, this has been mentioned, but it cannot be overstated, and that is the long-term results of your child's treatment that is being done now will not be available for another 40 or 50 years. which is not helpful in making your decisions now, but it's just the reality of how this works. And we just try to learn as we go. We're basically kind of fixing the train as the train's moving down the station and doing our best as we go. Okay, so in terms of long-term outcomes, we talked a bit about this. So for non-operative curves or curves that are less than 50 degrees, those ones that really slow down, don't progress much over time, what does that look like? And that's whether or not you were braced. So the best study, the biggest study, is pretty much positive news. People have referenced this. It came out in 2003 in JAMA, and it basically looked at over 100 patients in Iowa who were treated for scoliosis between, I think, 1932 and 1948, and looked at them 50 years later. Asked a bunch of different questions and compared them to age-matched controls, meaning just people walking down the street of the same age, and asked them a variety of the same questions. And as I mentioned, it's mostly good news. So the biggest thing, I think the bottom line is mortality rate was equal. So this type of scoliosis does not kill you sooner. At least we can't prove that it does, but it does not. Mental health was the same, so depression rates were the same, marital rates were the same. When controlled for pain, work and functionality were the same. Pregnancy rates the same. C-sections actually statistically significantly lower in the scoliosis group than the non-scoliosis group. And we'll get into that a little bit more in another slide, but essentially mostly good news. But everything is, I ask my son every day how school was, and he always gives me this. So that's a little bit of the reality. And so the sideways arrow, somebody mentioned about shopping for clothes, so body image was slightly lower in the scoliosis group, and that ranged from being slightly dissatisfied to slightly satisfied versus being slightly satisfied to moderately satisfied with your body. And, show me a 70-year-old who's like super happy with how they look. They probably need a cataract surgery. And then the other sideways thumb is back pain. So patients with scoliosis, on average, were more likely to experience back pain at some point. So I think it was 77% of scoliosis patients had back pain at some point versus only 35% of non-scoliosis patients having back pain. However, for those patients who did have back pain, either with or without scoliosis, the intensity and the severity were the same, and the vast majority of that was moderate to little. So you're more likely to have back pain, but it's not going to be debilitating, it's not going to be terrible, and you're going to do overall pretty well. Now, the one down thumb, there was one patient in that entire study who took narcotics for the back pain, and that was a scoliosis patient, but otherwise doing pretty well. Now, there's a giant asterisk to this study, and this is teenagers during the 30s and 40s. So these were kids who were teenagers during World War II in Iowa, and I think that translating those results to modern society, where 50 is the new 40, and everybody's on Facebook in a bathing suit, and life is very different, I think we have to, be cognizant of that and take it all with a grain of salt. However, the picture is mostly rosy. I'm probably talking too long, so I'm going to speed up a little. In terms of patients that were treated with fusion, that asterisk is again to represent the fact that this data does not represent our modern techniques. This is the stuff that Dr. Wenger was talking about, the Harrington rods and the Cottrell Dussé instrumentation, because that's what we have. Really, about 25 is the longest study that I've found, 25-year follow-up. And again, the news is mostly good. So if you look at health-related quality of life or patient-reported outcome scores, and that's not us looking at the x-ray, that's us asking patients, how do you function, how's your life, how's your pain, how's your self-image. Overall scores for patients 25 years later, this is mainly out of Denmark, Sweden, again kind of captured populations. Overall, the results were the same, even compared to people who didn't have scoliosis at all. So I think Dr. Shaw's point is extremely important, that really what you should be comparing is somebody who received treatment versus had the same condition and didn't have treatment. But even in the unfair comparison of a patient without scoliosis compared to one who had surgery, overall, the results were fairly similar in how you function in life. Now, the sideways thumb. When you drill down into some of the categories in those surveys that we asked, there were a few differences in self-image and then in function, with that being a little bit lower in the patients who received treatment of fusion, but everything else, again, kind of summed out evenly. And then the bad news is that, some people have alluded to, trying to stay out of the lumbar spine is better. So the lower the fusion goes, most studies support that that does a bit worse over time, specifically with regards to back pain and then function because of back pain. However, sometimes your curve involves your lumbar spine, and you have to include it, because not fusing it is even worse and more of a guarantee that you're going to have problems than if you leave it unfused. But I think all of us are trying very hard to stay out of the lumbar spine. The studies that support this most strongly, those studies really, those techniques really didn't focus on the side view of the spine, maintaining that alignment, avoiding the flat back. And so I think even going lower in the modern era is going to be better than it used to be, but still not ideal. Okay, finally, pregnancy. So as I tell my patients, someday, many years from now, when you're in a committed relationship, somebody who loves and respects you, you may want to have children, and that's going to be a long time from now. When that happens, you may wonder how your scoliosis is going to impact it. It's an important question. I think parents may ask that a little bit more than kids. And the answer is mostly good news. So in terms of kind of all comers with scoliosis, the data is not great. So in an ideal world, every study would be prospective, randomized, and controlled. And what that means is that we sign up patients before they receive treatment. We give them, just based on chance, a treatment or no treatment. They don't know what they got, we don't know what they got, and then we check them 50 years later and see which is better. And that doesn't exist. Nobody's going to do that. I'm not going to deny surgery for a patient if I'm really confident it's going to be better. And as a parent, you're not going to deny your child treatment if there's a chance that life might be better. So when it comes to pregnancy and scoliosis, the data is, sorry for the word, but crappy. There's no other way to describe it, but it's the best we've got. So there have been many studies, most of them poorly done, but in 2017, so just last year, there was a meta-analysis. And what a meta-analysis is basically big data before big data was a thing. So what we try to do is we say, okay, well, we have all these studies that aren't great, but if we pool all the numbers and look at it again with statistics, can we kind of tease something out from all of the noise? And so this meta-analysis looked at over 20 studies with a total of 3,000 patients, so pretty good numbers. And what they found is that in terms of success and timing of pregnancy, that patients with scoliosis maybe got pregnant less frequently, although nobody asked if they were trying to get pregnant or not, so that's a big confounder. And then maybe needed fertility treatment help a little bit more frequently. So one study quoted a 7% rate of IVF treatment for scoliosis patients versus a 2% rate for non-scoliosis patients. So it's statistically significant, but still not huge numbers. So success is probably the same, maybe a little bit worse, but kind of confusing data. And then in terms of timing, women with AIS had babies in the same numbers, at the same maternal age and gestational age, meaning they basically, if they're going to have babies, have them similarly than if you did not have scoliosis. In terms of curve progression or perinatal issues, patients with scoliosis who got pregnant, it probably increased their curve a little bit, but not in a clinically significant way. So with all of that, carrying a baby, carrying the placenta, carrying the late night ice cream, etc. It's a lot of stress on your back, and so it can make the curve progress a little bit, but not clinically significantly so. And then in terms of back pain, patients with scoliosis were more likely to experience non-debilitating back pain during pregnancy than their peers without scoliosis that are resolved at the time of delivery. So you would be maybe more likely to have a bit of back pain, but it won't be terrible, and it'll go away when the baby goes away. And then finally, in terms of mode of delivery and complications of the pregnancy, no difference. So C-section rates, exactly the same. Some studies suggest maybe lower in scoliosis patients, and then there was no increased risk of things like alpha-bacteremias or NICU stays, etc. So that's for kind of all comers, and specifically for patients who have had fusions. You can have an epidural. It might be a little bit harder, but don't let your anesthesiologist tell you that it can't be done, because the research shows that it can. It just might take a few more tries, or being a little bit creative, but it can be done. And then one study said maybe a higher rate of vacuum-assisted delivery for scoliosis patients, but not terribly so. So bottom line is, if you want to get pregnant, you can. Maybe you need a little bit more help, but probably not. Everything's gonna look pretty similar, except for maybe a little bit more back pain that'll go away when the baby comes, and then everything else hurts. And then you can have an epidural, it just might be a little bit tougher, and just know your levels. Because if you had just a selective thoracic fusion, for sure your OB should get lifted in an epidural, because they didn't touch your lower spine. And I think that's it. Thank you.
We think we've heard enough from Supin already, so we're going to skip his next talk. Anyway,